This is a little bit of an unusual setup. We are actually here also live as part of the Michigan Society for Respiratory Care Fall Conference. So we've got a room full of respiratory therapists and respiratory therapy students and other stakeholders who are going to be learning with us today. Officially now like to welcome everybody to the World Oxygen Day Stakeholder Summit. Again, this is a new thing, so I appreciate you bearing with us as we take care of some of the glitches and figure out exactly how we're doing this. This is our very first World Oxygen Day Stakeholder Summit because this is our very first World Oxygen Day. My name is Mike Hess. I am Senior Director of Public Outreach and Education for the COPD Foundation. At the foundation, I lead our Oxygen 360 initiative, where it's basically our moonshot project, where we're trying to drag oxygen therapy into the 21st century. And we hope to do this through a variety of advocacy efforts, awareness events like World Oxygen Day, and our hope is to help people around the world better understand the importance of oxygen therapy, the experience of being on oxygen therapy, and frankly, oxygen overall. One of our key inspirations for this event, this effort, is a gentleman by the name of Dr. Thomas Petty. Dr. Petty has, on more than one occasion, been described as one of the fathers of modern pulmonology. His research helped lay the foundation for much of what we have for oxygen therapy guidelines these days. Later in his life, Dr. Petty actually became an oxygen therapy user himself after experiencing some health issues. He ended up writing a series of books called Adventures of an Oxyphile that related his experience on both sides of the stethoscope, really, as well as sharing stories from other people on oxygen therapy in the hopes that we could all a little bit better understand that experience. In his words exactly, we are all oxyphiles. That is, we all love oxygen. We all need oxygen. We all love oxygen. And oxygen is an essential part of life. So we hope to honor that legacy with this year's World Oxygen Day theme of Team Oxyphile. And we are working to remind the world that everybody needs oxygen. Some bodies just need a little bit more. We also hope to honor the legacy of one of our original World Oxygen Day advisors, Louise Hobden. Sadly, Louise passed before seeing the vision of this day come into fruition, but her memory lives on in these activities and with your support. So I hope that sets the stage a little bit for what we're doing here today. With the gracious support of our partners, we've brought together a group of experts from the oxygen therapy community with a variety of perspectives to share their thoughts on the biggest issues facing oxygen therapy, people prescribed oxygen therapy, and how we can all work together to overcome those challenges. Our aim is to help everyone understand oxygen therapy a little bit better, reduce some of the stigmas and stereotypes associated with oxygen therapy, and to encourage additional research and innovation in this area in order to help everyone in this community truly live their best lives with equipment that matches their goals, values, and lifestyles. So with that, I'd like to pause for a moment and recognize that one of our scheduled advocates, Art Randolph, is having a health issue today and unfortunately is not able to be with us. So of course, Art, our thoughts are with you and we hope you have a speedy recovery. We do fortunately have another expert who has very graciously been willing to stand in, and I will be excited to introduce him in a few minutes. Finally, I'd like to take a moment to also acknowledge our international attendees at this time. We recognize that each region, each country has their own distinct set of barriers, concerns, and issues surrounding oxygen therapy. We certainly cannot address all of that in 60 minutes. The 60 minutes or so we are allocated here. However, we also recognize that today is a first step. And many of the issues we'll be discussing today also perhaps have some hidden lessons that we can all learn from. For example, even in a relatively resource-rich country like the United States, we have a variety of areas with very limited access to pulmonologists, other specialists, equipment providers. And so discussions on how to improve access to oxygen therapy for those folks may end up also helping people living in other similar areas of the globe, and vice versa. We may also see technology that is being developed in other parts of the world be of benefit here. So for those in our international audience today, we ask your indulgence. We ask for you to keep an open mind, and we certainly ask for your collaboration as we continue to understand some of the barriers in acute care in the hospital and outside the hospital as we continue with this work. So without further ado, I'd like to hand it over to our first panelist, who will first introduce themselves and then let us know what they think are a couple of the biggest issues facing oxygen therapy today. So to get the conversation started, I would like to introduce Dr. Anand Iyer. Dr. Iyer.
Excellent. So I'm Anand Iyer. I'm a pulmonologist at the University of Alabama at Birmingham. I see patients in the clinic, in the ICU, in the hospital, and I built a pulmonary clinic just down the street from the academic center for people who are underinsured and uninsured. And so this is a passion for me to help that population out as best as possible. And for my 2 points for today, I want us to focus in on, or at least bring the context to, in functional independence and then equity. So we all know that supplemental oxygen is so important for people. It's life-saving and it's vital. But as we're prescribing that, the clinicians in the audience, think about the inadvertent side effects of the heavy, bulky tanks and trying to move these objects around as you age and get older. I just want to make sure we don't forget about that context, because some of the research we just recently published in the Annals of the American Thoracic Society showed that people who live with COPD and use supplemental oxygen are at twice the risk of having social isolation and loneliness due to their tanks limiting their ability to have mobility and independence. So we need more portable options from the oxygen community. And then second, equity. I built a clinic, again, for underinsured and uninsured people in Birmingham here in the Southeast. Access to portable tanks and that sort of thing is very limited. And so for some patients, it might be easier to obtain more portable options, but for mine it's very difficult. And with competitive bidding, the number of DMEs that are available are limited. And so just as Mike said, it's even in our own backyard, this is a problem for people, and especially my patients who report these issues all the time, and getting the tanks they need to help them get out in the community and be independent. So thank you very much. I'm excited to talk some more about this.
Great. Thank you, Dr. Iyer. Next up, just basically on the order of our screen here, I would like to introduce Chrysalis Ashton, our other clinician representative today.
Thank you, Mike. My name is Chrysalis Ashton. I am a respiratory therapist, and I am the Director of Clinical Operations for CareLink Medical, which is a large regional-based DME here in Michigan, where we are live. So my 2 issues, my top pain points from the DME perspective, are going to be, no surprise, reimbursement. So reimbursement has continually fallen over the years with competitive bidding, with issues with rural access, and that does limit the service levels and the equipment that we're able to provide to our supplemental oxygen patients due to, again, the falling reimbursement. The other pain point or issue that we run into with DME, and this comes from the perspective also of being a respiratory therapist, is the technology limitations in oxygen therapy. So as Dr. Iyer mentioned, there are just not great portable options for patients. The tanks are heavy, they don't last very long. Some patients don't deal with the pulse dose very well, so that can be a challenge. And then cost is also an issue as well, because again, reimbursement is so low. So looking forward again to talking more with the panelists here today with more issues facing the oxygen community.
Thank you, Chrysalis. Appreciate that. Next up, we're going to get into the real subject matter experts here, our patient advocates. So first, I'd like to hand it over to Karen Smoot. Karen, please introduce yourself and let us know what you feel the issues are.
My name is Karen Smoot, but I see John on. Anyway, I hope you can see me. My name's Karen Smoot, and I was diagnosed with IPF, idiopathic pulmonary fibrosis, in 2011, and with pulmonary arterial hypertension in 2019. And I'm speaking from not just a personal perspective, but I also facilitate and have facilitated the IPF support group for about 10 years. So I speak from those members of the group also. I would say that one of the most critical issues that we face is the lack of follow-up. And when I say lack of follow-up, I mean on the part of really who I consider 3 important principles in the care of patients that are on oxygen. One is the pulmonologist. 2, the respiratory therapist, and 3, ourselves. And to explain a little bit more in detail, but I think that once it's determined either by various tests or nocturnal test, how many liters of oxygen we should be on, and then that is ordered by the physician, the DME company, the durable medical equipment oxygen supplier, delivers the concentrator or portable or both to our home, tells us how to set it up, and tells us how to order the supplies. And then we may be on that same amount of liters of oxygen for quite some time. And so often we talk about in our support group is to whose responsibility is it to really follow up on that. And so in terms of trying to get with a pulmonologist, and we have found that in various areas of the country, we may not see our pulmonologist except maybe twice a year. And they don't necessarily ask how many liters of oxygen we're on. And the respiratory therapist that comes to with the at the request of a durable medical equipment company, and the respiratory therapist that comes and explains how the equipment should work, and measures us on that liters of oxygen we may never see again. And then ourselves, we sometimes wonder, we go along merrily on our way with the amount of oxygen that we have initially been prescribed and never ask anything more about it. So I think we are all very much responsible. So I hope to talk more about this and answer any questions that you may have in the group.
Thank you, Karen. And then certainly, last but certainly not least, our special guest star for the day, who again was very graciously stepping in for the ill Art Randolph, a good friend of mine and another one of our folks on the Oxygen 360 World Oxygen Day Advisory Board, Mr. John Linnell. John?
Hi, I'm absolutely thrilled and delighted to be here, albeit at the last minute. And I'm going to go quick because I tend to be wordy. I promise I won't be, but I have 4 things I'm going to bring up. One is travel. I like to travel. Traveling with oxygen is tricky. All airlines have their own regulations and their own forms of paperwork. It's difficult. It can be done, but it's difficult, and that needs amending. Second, rural versus metro-urban healthcare access. It's terrible. I was diagnosed when I lived in the metropolitan Phoenix area. A lot of old people down there. That means there are a lot of pulmonologists down there. Not so in rural Wisconsin, where I live now in a town of 4,400. There are no specialists at all in my town. I have to travel an hour and a half to see a specialist. Third, the ability to have your prescription written right and talk to your doctor. And I believe that Karen brought this up initially, and I'm going to harp on it. You need, and to quote Tom Petty, titrate to saturate. Titrate to saturate. Your doctor has got to give you permission to do that. It's incredible how many people say, well, I'm on 2 liters. I can't turn it up. Mm-hmm. And I'm on 86 percentile, SpO2. Ridiculous. How come the doctor can be at 96, but you have to be at 87? Hello. So there's something wrong there. We can get into that later if you choose. And lastly, liquid oxygen. We need to bring it back. We need to bring it back. I was honored to be a participant and speak at the ERS in Milan, Italy last month. Arranging my oxygen there, I said something about tanks, and the oxygen supplier said, we can't lose our license. We can't give you tanks. Evidently, the standard of care in Europe is liquid. I have liquid. I'm spoiled. I want to go back. I want to move to Italy. But anyway, It's absolutely ridiculous that people that have high flow rates are homebound. They're unable to leave their home. This is America. This is America. Well, we can't do things like this. It's anyway. Enough said. I got my 4 points in. I'll wait for the questions to come. Thank you, Mike.
Thank you, John. I see a couple of common threads here that I think join in a couple of different ways. Of course, independence, mobility, movement, travel, all that sort of thing. And so the portability of oxygen is clearly a very key issue. And so actually I would like to get Chrysalis's thoughts on this, because as John mentioned, we used to be able to have liquid oxygen, which came in a large container, and it lasted for quite a while. But we have unfortunately lost that ability, certainly here in the US at least, where we have perhaps a little bit different payer system. So Chrysalis, I'd like to get your thoughts on, first of all, why we lost access to liquid oxygen, and then how we might be able to get that back somehow.
So yes, liquid oxygen. It's very rare now to find a DME that will provide liquid oxygen. And it goes back to my top pain point, and that is reimbursement. So the way that Medicare specifically handles reimbursement is you get reimbursed for a stationary oxygen system and a portable oxygen system if the patient qualifies for both stationary and portable oxygen. There is one rate for any system. It is up to that DME to decide which system makes the most sense cost effectively to provide to their patients. And it used to be that reimbursement was to a point where we could provide concentrators, liquid, portable oxygen concentrators, tanks, and even the services of respiratory therapists to do those follow-ups that Karen mentioned. But unfortunately, again, reimbursement falling continuously, competitive bidding really threw a wrench into that as well. And most DMEs have decided that they aren't able to stay in business. Some weren't even able to stay in business and still provide modalities like liquid oxygen. So in order to bring that back, naturally, reimbursement needs to be adjusted again, and it needs to go in the opposite direction. It needs to go up. So very excited that we've got the legislation going, and then forgive me, I don't remember the actual numbers of the bill, but I'm sure there's others that do, which would provide better reimbursement for not only the liquid oxygen, but hopefully the services of that respiratory therapist to do those titrations, do those follow-ups, and do additional education with patients. Because currently, most DMEs don't even have respiratory therapists do the setups of the oxygen equipment anymore, or the follow-ups, because it is just not cost effective for that company.
Great, thank you. And yes, the legislation that Chrysalis mentioned, again, sort of a US thing, but we can get some more information about that. There are various petitions and advocacy alerts and stuff out there. Everybody should be getting a post attendee email at some point in the next, hopefully a couple of days. And you can also get more information from that by going to our Oxygen Day website at worldoxygenday.org. I want to follow up with some of the education aspects in a minute, but first I want to hit on something that Karen said with that lack of follow-up, and I wanted to get Dr. Iyer's thoughts as a prescriber. Are we offering the correct tools for prescribers to really understand how to evaluate oxygen, and then reminding them to reassess it after an appropriate amount of time?
Good question. No, the answer is no, I don't think so. Simply, I think it's quite variable as far as pulmonologists' understanding of mechanisms to test and follow up for supplemental oxygen, to de-escalate oxygen when it's no longer needed. To remind her, that's a major sticking point. And then just that's pulmonary. But what about to do with primary care and other clinicians when pulmonologists aren't available? So mechanisms to increase education about it would have to go through professional organizations, COPD Foundation, ATS, others could participate in helping to understand it. I just went through this exercise simply last Tuesday, when I talked to a partner about an older woman who came to his clinic with their supplemental oxygen. I was talking tank terminology, M tanks, E tanks, these kind of things. And he had know some of the differences about the different sizes, how much they weighed. I've held them in my hands to sort of compare what they feel like, as opposed to the smaller tanks. How could that work if you're frail using a rolling walker? Which tank would be better for you? And I sort of educated him informally about, hey, ask her, watch her as she's walking. Where does she put the tank? How does she tote it behind her? Can she even carry that big 15-pound e-tank? So there's so many layers about how to do it, how to order it, to put the terms with portability in your prescription, and then when to follow up. So that's definitely worth more discussion.
Thank you. And that, to my mind, at least, that actually ties in with the question that we just got into the chat. And please feel free to use that Q&A feature so that we can hopefully get to several of the questions throughout the duration of the webinar, and then maybe at the end. And then we can also perhaps do some follow-up with you after the fact if we're not able to answer your question live. But one person mentions, can you address the ordering of portable oxygen concentrators from Amazon? Because that is a thing, and that also has to do with prescriptions. We have found over the last year and a half or so that there are a lot of these devices out there that are marketing themselves as portable oxygen concentrators, and they're not. They don't have any kind of clinical evaluation to them. They've been imported from wherever, and they make very unusual claims like providing very high flows of oxygen that we might be able to get with liquid oxygen, but certainly not with other technology that's on the market right now. And we are really trying hard to eliminate, and the prescription element of it is they are available without a prescription. You can just load up your Prime Day cart and get them shipped right to your door. And we know that because we did that. We ordered 3 of them last year with the foundation. I used Dr. Rich Casaburri's lab out in California and put them on a metabolic simulator, and essentially found that they weren't up to snuff. So that is certainly something that I would like to see addressed. But I also think that it's very important that if we're going to say that you can't get an oxygen concentrator without a prescription, we do have to provide our prescribers with those tools so that we can actually do those appropriate prescriptions. Karen, so I'll hand it back over to you because I'm curious, what would you say from a patient perspective? What kind of, let's say you're new to oxygen therapy, what kind of follow-up, what kind of time frame does education go along with that? What in your perfect world, what would a new oxygen setup for the first for whatever duration until you're comfortable with it, what would that look like to you?
I think in asking them questions, that if you're fortunate enough, and to Chrysalis, her comment about the fact that not all DME companies even have a respiratory therapist that assist in delivering the oxygen. But let's say you have one, and they've evaluated, and whatever number of liters that you're on, they feel is, they've evaluated and determined it's sufficient. But what the question that you don't ask is like, is this going to be like this forever? I mean, how long? And we don't, or at least, the people that I talk to don't ask that question. So if they're 2 liters, if it's determined that they're on 2 liters because of the testing that they did, the nocturnal testing that they did, that their heart or their O2 sats went down at night, then they think, well, then that's probably okay, because you haven't necessarily been out of breath anyway at night. So you don't know whether or not it's affected you. It's only because the pulmonologist has told you that, based on the test, your heart's going to work too hard. So therefore you need oxygen at night. So that's kind of the end of story at that time. So unless you have more breathing problems later on, you aren't even asking that question. So I think that there's a responsibility on the part of the patient to at least ask more questions about it, because when they see their pulmonologist, because of the lack of the number of pulmonologists in their time frame, they may only just test to see to hear your lungs. That's it. They aren't even asking you about the oxygen. So I think to answer your question, Mike, that I think you have to ask those questions as to how long is it sustainable? If you are taking your O2 sats and you're on 2 liters of oxygen and you're always over 90, maybe it's fine. But I think it gets down to that we as patients don't always ask the right questions to the right person.
Can I add something just about education? So to Kieran's point and to my point earlier about not having respiratory therapists actually do oxygen setups or follow-ups anymore, I would like to speak to the oxygen users and patients on this call and say it's still worth asking about. It's still worth asking your durable medical equipment provider, your oxygen provider, if they have a respiratory therapist on staff, and if it's possible that they come do more education, a pulse ox study on you, something. They may say yes. They will most likely not send a respiratory therapist out for every single patient, but if one specifically asks for it, or if even better, if their doctor calls and asks for it, then it's very possible that you could get that service from them.
What kind of information or education, training, whatever word we want to put on it, would a respiratory therapist proactively provide
To an oxygen patient?
To a new oxygen patient?
So what we are looking at is the whole picture of the disease process that's going on. So you're starting on oxygen, but where is this potentially going to go in this process? So a common, of course, diagnosis is COPD. And as most of us know, COPD is a progressive disease. And luckily, if we can catch them when they're first put on oxygen, we can often prevent additional hospital readmissions, additional equipment if needed, or even get them additional services and equipment sooner if we're catching them that early. Unfortunately, again, because of the reimbursement issues, we aren't always catching them that early, but able to provide more of that disease education before it gets to a point where they've been in the hospital 12 times that year. That's our goal, and that's where our industry is shifting. But we still have a lot of work to do to get to that point.
Dr. Iyer, back from the prescriber perspective, as a pulmonologist, or with your many hats with your clinics, speaking to equity and things like that, is that instruction that your staff can sometimes provide?
Yes, but it's quite overwhelming in a clinic when you're talking about indigent care or sort of care for uninsured patients. The clinic itself is quite large, several thousand that we would care for that I'm on my panel. And we have one RT that I might be able to use to help with that situation. And so there might have to be innovations in who can provide that type of education and who would be within their scope of practice to understand that. So sometimes the nurse can understand how that would go. But man, it would be great to have more respiratory therapists to help with that. But and maybe there's a virtual way to sort of help people telephonically or virtually through video, get some education that way. I know John was raising his hand. I didn't want to make sure we took away all the time from him. So what you got there, John?
I just wanted to comment on both what you said and what Chrysalis said, and that's the importance of the RT. And no offense against you, Dr. Iyer, but the physician does not know nearly as much about portable oxygen concentrators and modalities of oxygen as a respiratory therapist would, because you're more in the diagnosing end of things. And I don't see how you could possibly understand how umpteen million portable oxygen concentrators work. So not taking away from your profession, but we rely so much on the RT. And back to what Chrysalis was saying, in the home setting, I think it's very important if you could get an RT to come from your DME to come to the home to do a home evaluation test. I have stairs in my home. When I do an oxygen study or a walking test at my clinic, I'm walking up and down a level plane. It's not realistic. We need to have these tests done in real world settings by RTs, because they're the important ones to do it. So I hope I hope I said that right without offending anyone.
Oh man, that's fine, John. You could totally say that, because
John.
No, that's a great point that you bring up, because I don't think my fellow pulmonologists know as much as just like you said. It's a layer of understanding of supplemental oxygen that we're not necessarily taught that, and with the changing sort of tanks and terminology, and even how to order supplemental oxygen that supports functional independence and mobility. That's my layer of research into geriatrics and palliative care and supporting people at home, maintaining their independence. But that's my frame and something I bring to the table that I'm trying to educate other pulmonologists to do the same. When someone walks in the room, I'm watching that person come across and realize that person's not going to be good for a really heavy tank. Like, we have got to figure out portable options for that person and make sure that that long tubing at home on the concentrator is not going to trip them, because their frailty might predispose them to falls. And now this new research showing that could be inadvertently making people more isolated and lonely because they can't get out, can't go to their places of where they want, in the community. That to me is a fascinating conundrum. It's supposed to promote your more survival, but it's also hindering you because it's too heavy. So there's a balance there that has to be met with tech and innovation there that can get people at cost, better cost, to be mobile and independent. So all to your points, John.
I want to take a minute and loop back around, because there's about 3 points that are kind of all intersecting with some of the questions in the chat, some points that have been made. Of course, we've talked a lot about the importance of respiratory therapists to provide this education to the roughly 1.5 to 2 million folks in the US who are on oxygen therapy. However, in most of the world, there are no RTs. There are some countries that have a profession like ours. Otherwise, it's a respiratory nurse, it's a physiotherapist, that sort of thing. So they don't necessarily have that access to the kind of knowledge that we take for granted as RTs. But there's also the telehealth element to it. And I know that that's a huge part of some of the global collaborations that we're working with to try and get, leverage that technology so that we can have these international collaborations. So is there a potential mechanism to use respiratory therapists as a telehealth resource, first domestically, most likely, but then also as a resource for some other countries? I think I'd like to hear from the patients on this one, just to get your thoughts on how comfortable you feel you would be with telehealth, or I know you're both active with a variety of support groups, how comfortable your communities would be with telehealth. And then we'll talk about what we might be able to do with that.
Okay. Well, in terms of telehealth, I would be very comfortable with it. I think it depends on what the questions are. One thing that I was going to mention when we were talking about respiratory therapist and the value of respiratory therapist is that so many people who are on oxygen do not know anything about efficient breathing, how to breathe efficiently. And, it's always been a thing of mine, because I have a very good friend who's been teaching breathing for the last 30 years. And so, and she has done it with our IPF support group, taught breathing via video, but it's not as effective. So I think it kind of depends on what's being asked. If someone is on video and they are asked a question as to how efficient their breathing is and how they do breathe, whether or not they're mouth breathers or breathe through their nose, then I think someone can assist them in that way. But I think it's more valuable than not having anything. To have telehealth, and I think it just depends on what the question is, and how truthful someone is in relating that information about how they use oxygen and what their daily activities are. So I think that's an important component to consider when you're considering telehealth.
Absolutely, John.
My comment on that, first to respond to what Karen said, she's absolutely right. But I just in my years of being a manager when I was working, people understand things if they understand the whys and the hows. You have to understand why you need to do this. In other words, pursed lip breathing. What does it do? And when you explain that the back pressure, you have to explain it in simplistic terms, but the fact that the back pressure keeps the airways open, allowing more of the bad air, the old air, to escape. Oh, now I know why. If you know why you're doing it, you're more apt to do it. If you understand the whys, you'll adapt more. Now, back to the original question and my main point, telehealth. In interest of full disclosure, I work part-time for a startup company that actually does online telehealth pulmonary rehabilitation. And I think what makes the difference, because there are a lot of companies out there that have videos. You pay $15 a month, you watch the videos, but true pulmonary rehabilitation is being monitored. And a company that does it right will have you monitored with a pulse oximeter, a blood pressure cuff. If you need to have it, something that checks your heart, bradycardia, tachycardia, etc. So you're monitored. You're monitored and you're watched and you have live one-on-one. So in other words, it's just like being at the clinic.
Mhm.
It's wonderful. It takes the burden off the patient. And true, I've got a vested interest in it, but what I'm saying is it allows far more people, especially in rural areas, to participate in pulmonary rehabilitation where they might not otherwise be able to or willing to. So I guess that's it, in the short run, that's my answer, Mike.
I think that's great. And I think that also ties in with another question I saw pop through the chat about providing education through pulmonary rehab. Of course, we're also trying to re-engage virtual pulmonary rehab and get that paid at the same level as it was during the pandemic. One question I might consider, it's just on my mind, we talk a lot about this whole idea of the digital divide when it comes to things like telehealth and even in rural areas. I agree, I have spent plenty of time in rural areas. I know that it's difficult to get access to these specialists and things like that without that technology. But there are also a lot of people who don't have access to the technology itself. And I think probably some of our international colleagues can attest to that as well. So I wonder, and Dr. Iyer, maybe this is back to some of your work with your population and advocating on behalf of the equity and everything else. How do we ensure that we don't look at telehealth as, say, like a shiny new toy, and we're going to heavily rely on that while still maintaining access for folks who don't have or don't want access to that?
Oh, that's a great point, Mike. We have to be careful that as tech advances, you don't leave people in the dust. And in Alabama, for instance, where I'm at, there's significant broadband access limitations, and that's the same case in many rural areas. So those areas are not going to keep up when you've got fancy tech that you're trying to deploy, and they're the target area that you're wanting to reach because they can't make the 10 miles or more to get to pulmonary rehab. That's a good cutoff that we know that if it's beyond that, they're probably not going to get to that rehab center. And there aren't that many of them even in Alabama. So we would love to have that virtual rehab expanded in numerous places, but then that digital divide is happening and it's real, not just urban to rural, but within urban and inner city, sort of impoverished areas lacking access to tech. So I think if we have knowledge and awareness that that's happening, B, think about ways that we can advocate for policies like broadband expansion in your states where that's not there. Those have to fundamentally be there from a layer one so that tech can then be built on top of that. Otherwise, you're going to just separate a have and have not situation pretty quickly, as experienced in the pandemic. And many of these populations are just good at doing it. You can't limit older adults. They want to do tech too. People in different rural areas want the tech, but you can't do tech when you've got this digital Wi-Fi signals aren't existing anywhere. So it's great to keep it in mind, but also think about advocacy to policy standpoint.
Great, thank you. So again, we've got, I can't even tell you how many fantastic questions are in the chat right now. And there's unfortunately no way we're going to be able to get through all of them, but we're certainly going to use this information to help guide some of our future efforts, future educational outreach. Again, this is day one of a new era, hopefully, and we're going to keep driving forward with that. But a couple things specifically pop up at me. And we talked a little bit earlier about the use of non-prescription oxygen concentrators that you can buy online, or avoiding the use. A question in the chat is, are you concerned at all about the sale and use by patients of non-healthcare approved oximeters? FDA sent out a warning about this issue earlier this year, but we haven't really heard anything since. So I think, well, I'll get the RT perspective on this. You've been quiet over there for a minute. So.
Oximeters, I would say, like any medical equipment, be careful what you buy online. The devices that, the DMEs use are going to be tested, vetted by respiratory therapists, compared to other devices in the market. And buying something on Amazon, you just don't know what you're getting, or you're getting what you're paying for if you're paying $10 for it. So it's challenging. We have patients that come in and we will test them on our equipment, and they'll have their own little finger device, which is what they're using at home to determine if they need their oxygen, if they need to turn their oxygen up or down. And it's nowhere near reading the same as what our clinical level equipment is. So it's definitely concerning. It's just as concerning as buying the oxygen concentrator on Amazon. You just don't know what you're getting or what that's giving to the patient. And if you're using those devices to make actual medical decisions, that can be tricky.
Karen, John, do you have any experience with these devices or recommendations to people in the audience that might be considering one of these?
Yeah, I recently asked a question about to a respiratory therapist about the comparison between what you view on an Apple Watch and your blood oxygen level. And I'd be anxious to see if Chrysalis agrees with this. What he said is that it's very accurate to about 1%. And so I think that various people use various devices, but I think for the most part, if they're tested by anything, and every time they go to a physician, if they're tested at all and can do that comparison to determine if their device is pretty accurate. And that's why I mentioned the Apple Watch, that some people are using that and to monitor it more closely.
I can't speak to Apple, but I have to imagine their technology is a little better than Amazon's $10.
Oh, you're right. Yes, you're right.
But I would encourage patients to take their Apple Watch to their physician's office and compare, or to their DME provider if they have that service.
Right.
But
yeah.
I think I'm sorry. I'm sorry. I didn't mean to cut you off, Karen.
No.
I just think it matters when and how you take the test. People say, well, how's your oxygen while you're sleeping? Well, when I wake up and check it, it seems fine. Well, okay, guess what? You're awake. I mean, so you need to have a decent one. And yes, I'll give a nod to one of our sponsors. This happens to be a very good Anand that happens to be Bluetooth. And so kudos to Anand. In fact, I believe they're the ones that actually invented the technology that most all of them use nowadays. And that's the end of the plug for Anand. I'll give you my address later if you want to send me a check.
Might have to edit that out for the recording. We'll see.
Well, that was obviously a joke. Anyway, it depends how you're doing and when you're taking it. A lot of the inexpensive pulse oximeters will not measure accurately when you're moving and walking. So if you're going down the street doing a power gate, chances are, from what I've been told, I'm not a clinologist or clinologist, it's probably not going to be accurate. But when you sit down, even the cheap ones are probably going to be accurate, but that's not giving you the information you need. So it's very important to understand you get what you pay for. So enough said. Maybe I don't know. Perhaps Dr. Iyer or Mike or Chrysalis or the clinicians on the line might want to chime in on that.
Definitely, I think we need to make sure we caution about is all the studies that have raised about the sort of racial differences. And so let's not forget about that. I mean, skin tone is showing differences in oxygen saturations that may have been inaccurate over time. And that is being debated. It is being sort of vetted even further and asking for more equitable representation of people with darker skin tones into trials related to the pulse ox. So let's just make sure that we don't forget about how that could give a plus or minus 4% saturation. That could be a pretty big difference in, you're 90, but you're minus 4 plus 4% saturation difference that you could qualify or you could not qualify. And in some of the studies, it's showing that those people were missing this occult hypoxemia that actually existed. So definitely worth discussion offline and pushing that sort of advocacy standpoint that there's more representation for darker skin tones in device development research.
And for the women that wear nail polish, I had heard, I don't know if it's true, but if you simply turn it sideways and bypass the nail polish, you get around that.
All excellent points, and thank you for bringing up all the confounding factors and the new research that's been out there. Switching gears a little bit, but also on the equity side of things, there was a comment in the chat that said, is our primary care providers in a better place to manage perhaps COPD in general, or oxygen therapy or anything like that? And I think that speaks to equity, particularly around the world, because, again, much like we have pulmonology deserts here in the US, we have a lot of folks who in other areas of the world may not have access to a specialist. So I guess, Dr. Iyer, I'll throw it back to you real quick and get your thoughts on the turf war, so to speak, between a pulmonologist and a PCP.
Well, there's no turf war. I would welcome my primary care clinicians all day long to help with that situation. But unfortunately, they are always emailing me or messaging me questions regarding supplemental oxygen due to comfort level and prescribing it. They are the first line of evaluation, and I don't think and we'll need to have that demonstrated about how much education they're getting regarding supplemental oxygen and when to do it and how to test for it and et cetera. So guideline evidence-based recommendations about prescribing it, but they are often the first ones that get it. So that are having to engage in that discussion without that formal background education. So it speaks to the need we would love to have wider education and bringing in our primary care colleagues into the fold to help with this, because we need all the help we can get regarding extra hands on deck. And that goes to Ms. Karen's point about getting them that follow-up. That person might be the primary care clinician who sees them in the interim, that 3-month short-term follow-up instead of 6 months later. You might see your primary care clinician, but if they're not engaged in the conversation or the prescription, then they don't know what to say, and they might continue the 2 liters just because the pulmonologist said it should be that way. So team science, teamwork, interprofessional nature stuff, we gotta get our whole, it's lofty, but it's essential. That's got to be the target.
So Chrysalis, a question for you again, as kind of arguably one of the gatekeepers, so to speak, of equipment. We're talking about how do PCPs and specialists, pulmonologists, how are we all communicating together? How are patients and caregivers communicating together? How can all of these groups kind of work together to improve that coordination and smooth the process of ordering and reassessing and supplying and that sort of thing?
I think that is where programs like Kelly and Brian have come in. COP navigators are amazing. And then also DME programs that are willing to provide that assistance. So we spend a lot of our time in DME coordinating just that. We have a primary care that is trying to order oxygen, desperately trying to order oxygen, and doesn't know how, doesn't know what the testing needs to look like, doesn't know what the levels need to be. and we are coaching them through that. We are helping them write prescriptions if needed to get that patient what they need. If we had somebody in the hospital that could help even sooner than that, that'd be fantastic. And then also helping with funneling those patients to pulmonologists if possible. They feed us, we feed them type of situation where we will help you, we'll bring these patients to you. We think they need these pieces of equipment, this oxygen, we can get them this portability option, et cetera. So it just needs to be one healthcare. I mean, I've said that many times. We all say that many times. We're all on the same team and we all have the same goal. We want this patient to be able to live long, healthy lives and not be hindered by their disease and not be stuck in their homes. So it's just coordinating all of that.
Live long and prosper, so to speak.
Heck yeah.
All right. Well, we're coming up on the end of our time together. I think what I'd like to do now is once again offer every one of our panelists here just a quick chance to kind of summarize what they in each person's view the big takeaway of today is, and perhaps an action step we can take to move forward and work on some of that care coordination and smooth things out a little bit. And we'll go in what I recall to be reverse order and go with John Linnell first.
I would like to, this has been a soapbox I've been on for years, and this is more to PCPs. In fact, I just got done answering a question in the chat about that. When someone goes to their PCP, they're weighed, they're measured, their blood pressure is taken, their temperature is taken, everything's done. There are 14 million people in the United States living with COPD that don't know they have it. We have to find the missing millions. And the way we do that is spirometry, simple spirometry. And that starts with the PCP. So this obviously is not a plea to the RTs because they know that. So it's more, please let your primary care physicians, let your family physicians know that they can help, because we all know the sooner you catch COPD, the sooner treatment begins, and the more quickly you slow the progression. True, we don't have a cure. True, it's progressive, but we all know the quicker you catch it, the quicker you can slow the progression and improve the quality of life of the human being living with it. So let's find the missing millions. And with that, I'll pass.
Karen, perspective from the pulmonary fibrosis ILD viewpoint.
I would add on to what John is saying about the importance of early diagnosis, because it's well known that in terms of idiopathic pulmonary fibrosis, that's one of the reasons they call it idiopathic, because it is not always determined early enough as to what it is. And I would definitely second the importance of early diagnosis. But one other thing I wanted to mention, even though I'm speaking from a patient perspective, I'm speaking from that perspective and saying that I really do honestly believe that we need to look at reimbursement for durable medical equipment companies, because it isn't going to change with the patient in terms of follow-up, as I mentioned initially, and with respiratory therapists maybe assisting better, and access in rural areas. It is not going to change unless we have better reimbursement through Medicare for DME companies. So,
Chrysalis, I suspect you would agree with that.
100%. And my big takeaway from today has been that it seems like all of the stakeholders in oxygen therapy are on the same page. We all agree that reimbursement needs to change. We all agree that technology needs to catch up. We all agree that patients who don't have access need access and need better follow-up with both pulmonologists and respiratory therapists. So that's encouraging to me. And now I think it's just, how do we move forward, and how do we advocate for our oxygen therapy users, as well as our DMEs, our pulmonologists, all of the stakeholders in this.
All right, Dr. Iyer, bring it home.
Thanks, Mike. And thank you. It's such an honor to be on this call with all of you. I want every clinician to think about practical implementation of oxygen for your patients and their families. Think about what their lives are like, their mobility and their independence, and take that into consideration when you're prescribing that they should be vital and life-saving and life-giving, and don't let it be something that hinders their independence. So think of ways to get them out and mobile as much as possible, which means you're going to have to educate yourself about the options that exist out there. And then two, as we're thinking about access, we need all the help we can get to take to Congress. I was at Capitol Hill in ATS this spring, advocating with my state senators about reimbursement changes, competitive bidding, how it impacted things, more liquid oxygen. So there isn't necessarily a great single ask I could come up with. It's just a supplemental oxygen crisis, and there's just major reform that's needed in this space that can help people with their well-being and independence and increasing access to rural and underserved populations. So there's probably better ways to say that, but it's just, it's something Mike and this foundation and others are working hard to try to do. So I'm grateful to be here and that everybody's listening and is excited, energized, mad, anxious about this problem, that we need to get it fixed because it's just limiting a lot of people.
Absolutely. And with all of that said, we're pretty much at the end of our time together today, but I would like to remind everybody that this is the starting point. This is it's not a finish line. This obviously is going to take a long time to rebuild a lot of these processes. And we're very grateful for the incredible support that the World Oxygen Day Project has received so far from supporters both within the United States and around the world. With that continued support, we'll be able to continue to support initiatives like the World Health Organization's recent resolution to improve access to medical oxygen. Again, we have talked largely about the outside the hospital use of oxygen, but there was a webinar a couple of years ago now where Dr. Anthony Fauci and former President Bill Clinton were talking, and they said that neither of them realized that there could be such a thing as an oxygen shortage until they started seeing preliminary issues of that in hospitals here in the United States. We know that's been an issue around the world too. And so part of this WHO initiative is to strengthen the security and access to medical oxygen. So we want to support those efforts. We want to support the legislative reform here in our oxygen system. And we want to work with partners who are committed to improving oxygen therapy through education, advocacy, awareness, innovation, other avenues. We like to say that by learning more today, you'll breathe better tomorrow. And so that's really where all of us sit right now. I invite anyone who is doing cool stuff in this area to reach out to us at oxygen360@copdfoundation.org so we can figure out how we can all work together and make that happen. Until then, I'd like to once again thank our advocates today, Dr. Iyer, Chrysalis Ashton, Karen Smoot, and John Linnell. Once again, our thoughts go out to Art Randolph. Hopefully he'll have a speedy recovery. And I'd also like to thank all of you in the audience and in the live audience here in Michigan and the virtual audience around the world for spending an hour of your time learning what some of these issues are and how we may be able to work together to make oxygen therapy a little bit better, one step at a time. We should have a survey that pops up as you leave the webinar. Please take a moment and fill that out. So again, we can get some more information about how we can better tailor some of our initiatives or find partners that we can work with to do all this stuff in the future. We also have a newsletter you can access at copdf.co/world O2 O2 day. It is case sensitive, so I said it is a little bit cumbersome, but certainly you can go to worldoxygenday.org and find all the applicable links out there. So until we meet again, I hope you all take care of yourselves and take care of each other. And on behalf of the COPD and Pulmonary Fibrosis Foundations, my name is Mike Hess. Happy World Oxygen Day, everybody.